Moving on, so most of my presentation from here on out will focus on the cancer needs assessment focus groups. So the Buffett Cancer Center created the Office of Community Outreach and Engagement as they're seeking to increase their NCI funding status. So there is an institutional need for this community outreach and engagement office, and the purpose of the COE is to guide the development and implementation of strategies to improve Nebraska's cancer-related health, focusing primarily on prevention and control, with a big emphasis on collaborating with community partners. And so the needs assessment was done in close collaboration with the Nebraska Cancer Coalition, as well as the state Comprehensive Cancer Control Program. And there were three primary aims of the needs assessment. The first was to describe the burden in Nebraska. This was primarily using secondary data sources. There is a report on this that we've already released, and so I'm not going to spend a lot of time on that aspect of the needs assessment. The second and third aims were really to assess the perceptions of different populations within the state, and that's what the focus groups were really focused on. And both of those two aims are really intended to inform aim 3, which is to help set the agenda for outreach efforts. So I have shown you both the secondary and primary data methods. Secondary data, again, was using publicly available sources, some of which had to be requested directly from DHHS, but others were available online. For the focus groups, we used a series of groups where we had met with our community partners to decide what the priority groups were to make sure that we were focusing on underrepresented or disparity populations. And so we decided to focus on rural areas, African American, Hispanic, Native American, and LGBTQ. The focus groups were actually conducted from February of 21 through January of 22. We are still trying to gather some additional information, but this is what we have to date. This was COVID era, and so the vast majority of the focus groups were conducted virtually by Zoom. We did have 2 meetings with urban Indian groups that were in person, but otherwise they were all by Zoom. Our eligibility criteria were people who were 30 and over and self-identified as either patients, survivors, or caregivers in Nebraska. And we recruited using contacts in the community, as well as flyers and social media posts. Our community partners included a lot of the local cancer centers and health professional organizations. And so we really relied heavily on those community partners to help recruit. We used a structured facilitation guide that had some built-in short poll questions or survey questions. And we used a directed content analysis approach for analysis, which for those of you who have not done qualitative work before, it's quite time intensive. And it was repeated versions of reading through the transcripts, going through codes.
I like the physical aspect of it. It keeps me healthy.
We have everyone
people working here.
I'm not sure if anybody is zooming in. Can you please mute? Thanks. So with the poll-based questions, we were able to develop some graphics, and otherwise most of the analysis was focused on looking at themes and quotations that illustrated those themes. So we had 11 different focus groups, 3 rural, 2 African American, 2 Hispanic, 3 Native American, and 1 LGBTQ. As you can see, we had 68 total participants, and the number of participants really varied based on the number of groups that we were able to host and recruitment efforts. So we really, although we worked for months to try to get more LGBTQ plus participants, we really struggled with recruiting that target population. The vast majority, about 58% of our respondents were female. People could indicate multiple roles, so you could be both a cancer patient yourself as well as a caregiver for someone. And so you can see that the roles were almost evenly split overall, but they really varied depending on the focus groups. We had no restrictions in terms of what type of cancer we were recruiting for, and so we had a lot of different types of cancers represented in these focus groups. with breast cancer being across the board the highest representation, and excluding the LGBTQ group, it was the only type of cancer that was represented in all of the other groups. You can see that there were some types of cancer that only had one participant. So due to space on this slide, I didn't include them as part of the table, but that information is available if you want it. So we started out the focus groups by asking some poll questions just to start generating some interest in the topic and some jumping off points for discussion. So we started the focus groups after doing some quick introductions by asking what their perception of their community's health status was. Overall, it was kind of fair to middling, and it really varied quite significantly across different focus groups. So within the rural populations, it was good to very good, but it's only when we get to the Hispanic and Native Americans that we have people who are actually indicating that their community's health is poor across the kind of as a general statement. Our follow-up question was, how important is cancer as a concern in the community? Keep in mind that our participants were cancer survivors and caregivers, so this was a personal issue for them, but we asked them about their perception of cancer as a community concern, and most of them indicated that it was moderately or very important. The biggest difference by group is that some of the Hispanic participants said that they had no idea. That wasn't one of the response options, but we added it in the reporting just because it was mentioned by multiple people in the Hispanic groups that they had no idea of how to assess that. In terms of outreach, it was also important for us to know where they were getting information. And so we asked them to check one or more of a list of options in terms of sources of information about cancer, and that could be about prevention, treatment, etc. And we contextualized this by asking, before the diagnosis, what were the sources of information that you had about cancer? Even though we contextualized it based on the discussion after the poll question, some of the people were reporting after the diagnosis, so that is a caveat. But the vast majority of people across focus groups relied heavily on healthcare providers, as well as family and friend networks. Again, the main point that I want to point out for this slide in terms of disparities is that it was only in the Hispanic groups that we had indications of no information about cancer at all. We had some people that were indicated during discussion that they didn't even know what cancer meant until they were being educated after the diagnosis. As a follow-up question, we asked what their most trusted source of cancer information was. Not surprisingly, kind of across the board, it was healthcare providers, although there were some subgroups that had more emphasis on family and friends. And again, we had some indication in the Hispanic groups that they had no sources of information. One thing that's interesting is that and we did ask about the most trusted source of information, so there is a little bit of misclassification compared to the other groups with the Native American groups, because it was a paper-based poll, and so some of them checked multiple answers, as opposed to the Zoom polling where they were only allowed to check one answer. We also had a sub-portion of the focus groups, like the latter half of the focus groups, we decided to specifically target on colorectal cancer because of the cancer disparities in Nebraska with colorectal cancer screening. And so the last half of all of the focus groups was specifically focused on colorectal cancer screening awareness and outreach suggestions. Kind of across the board, colonoscopy is the most widely recognized type of colorectal cancer screening. And again, as a caveat in terms of data collection, there was a lot of awareness of fecal testing, but lack of awareness about what types of fecal testing they were receiving or had heard about. So there was a lot of confusion about the different types of fecal testing. So some people in discussion indicated that they had heard or seen ads on TV for Cologuard, but they did not know how to classify that as FOBT fit or fit DNA, which it is fit DNA, but a lot of our participants did not know that. And so there is probably some misclassification in terms of the subtypes of stool-based testing. Awareness of different screening methods really varied across focus groups. And again, primarily in the Hispanic, to a lesser extent, the Native American and rural is where we're seeing people who weren't unfamiliar with any type of colorectal cancer screening methods. So as we were talking to participants, so I'm kind of jumping back to the beginning of the focus groups again, where we were talking about their experiences with cancer, we asked them just to kind of narratively tell us the story about how they were diagnosed or how their loved one was diagnosed. Some themes from the experience of diagnosis was that it's really important to have a primary care provider who is your point of contact in terms of getting test results. So some people indicated that they had gone to an emergency room or they saw an on-call doctor and they really struggled with getting their test results or with getting referred to follow-up biopsy testing. A lot of the different participants across focus groups, excluding the rural focus groups, which were primarily, the rural focus groups were predominantly non-Hispanic white participants, but across most of the other focus groups, there seemed to be a cultural or a practical reticence to going in to see a doctor unless you had really severe symptoms. And so there was a lack of annual physicals. There was a lack of screening as kind of a general way of approaching healthcare. And so those participants indicated more issues with, number one, getting testing, screening. And then we had at least two women, female participants who shared with us stories of going into the doctor where they thought that there was something wrong, whether they had felt a lump or the Hispanics called it a ball. Anyway, they went into the doctor thinking something's wrong, they were in pain, and the doctor not taking it seriously. And so that delayed their referral for diagnosis, sometimes up to several months. There was another Hispanic woman who was a caregiver to her husband, and he kept having kind of, it was portrayed as almost hallucinations in terms of some of the symptoms he was experiencing, where he would smell smells that weren't there. And so they repeatedly went in to try to get some sort of diagnosis to identify what was going on. And this female participant related that the doctor basically said to her husband, "Your wife is stressing you out. Like she's making things up. She's causing you to experience these symptoms because you're so stressed out with her concern about your health." And it ended up that he eventually developed some other symptoms and was diagnosed with a brain tumor. So doctors not taking patients' concerns seriously, although the minority of stories that we heard was something that was very riveting and very something that needs to be addressed. There were other examples of patients who described the need for themselves or their family or caregivers to really advocate on their behalf to get the ball going in terms of finding that diagnosis or in terms of getting the follow-up testing to get that diagnosis. So in terms of the cancer journey, so people had been diagnosed, we asked them to explain how they got transitioned into specialist care and kind of just to tell us the story of their cancer journey. And so some of the themes that emerged from those discussions were the importance of care coordination, specifically transitioning from that primary care or that original referral for biopsy or testing into treatment. And for the people who didn't have a primary care physician, there was sometimes test results got misplaced. They weren't informed of them. They had to do a lot of calling around to try to find out who they needed to actually talk to get the results and to get transitioned into that follow-up care. Patients told us both positive and negative stories of their experiences working one-on-one with their individual providers. And the overall theme that came across was that the physicians who were open to being asked questions, who informed their patients about the variety of different treatment options that were available and discussed pros and cons, tended to have really positive experiences about their cancer treatment. It was the patients who felt like their provider was a mini god, as one of them phrased it, where they weren't allowed to ask questions, or where the provider was very abusive toward them, where they had really negative experiences. Some of them were able to find a secondary provider, get a second opinion, get transferred to another provider, but some of them didn't have that as an option because of their geographical location. Another theme that came across was the support services that were available at an organizational level. So they identified people who had a nurse navigator or a care coordinator. Referrals to social work were important for assistance with social problems, which I'll social issues such as finances, gas, transportation. A handful of participants indicated that they were referred for psychological counseling, but that was not across the board as a typical experience. Financial support was huge, and I'll get to that when I move on to the barrier section. But participants shared that some of them received gas cards, hotel vouchers, meal vouchers, especially for those that had to travel long distances to get to the cancer treatment center. Some of them had help applying for medication assistance. Some of them had help applying for Medicare, Medicaid, filling out applications for family medical leave, those sorts of things. Some of them had assistance covering their rent and utilities because of the financial burden of the cancer treatment. They did identify some community-based organizations in addition to the cancer center provided social supports. Of note was the Grace Foundation that provided a lot of those financial assistance, as well as some housekeeping assistance, as well as My Sister's Keeper. Social supports were really valued by the participants, but a lot of them weren't always aware of the supports that were available. Particularly in the Hispanic focus groups, there was a lot of reliance on their social networks for knowledge or information. And so a lot of them, if they were well connected, were aware of resources, and others were sharing resources during the focus groups because there was that lack of awareness. Something to note when offering these support services, people's situations change over time, so it's not enough to just offer those support services on a one-time initial appointment. A lot of the participants indicated that they didn't want to feel like they were using the system or being a burden on the system. And so even though they might have had need, they were reluctant to make use of those services, and they appreciated being reminded that they were available if they needed them. There were definitely some geographical, language, insurance, and immigration status barriers to accessing those social supports. Social supports can also encompass kind of informal supports. And so that was another theme that came about in terms of people's support from family, friends, coworkers, church or religious organizations, the general community. Most people indicated that they did have some sort of family, friendship, or community support, but there were a handful of people who indicated that when they got the cancer diagnosis, their support systems disappeared from under them. Family members who said, "I can't deal with your cancer diagnosis, I'm leaving you." Or people who were older and didn't have good family supports. So it's important for us to be assessing those types of support systems so that we can hopefully make referrals to the organizational supports when those are needed. Treatment and side effects, although we didn't specifically focus on treatment side effects because those are pretty well known within the literature, our participants did mention that the treatment side effects did have some long-lasting effects on them. And there seemed to be kind of a general lack of understanding among the people who did talk about the treatment side effects, that it would be a long haul process, that they wouldn't just go through surgery or go through chemo or radiation and be able to immediately bounce back to their pre-cancer self. So patient education in terms of this is a lifelong journey, this is going to be a survivorship is long-term, that educational piece needs to be incorporated. By and large, our participants across focus groups were really happy with the cancer facilities that were available and very happy with the support staff. There were a few examples of people who, like one Hispanic couple that had some difficulty with language, where they indicated that they felt like they were very discriminated against and weren't offered the language support services, but they felt like they were being checked for immigration status because they had forgotten their ID card when they went to the appointment. So there are some examples of some of those support staff not being culturally sensitive, but by and large, our participants had really positive experiences with the support staff, the nursing staff. Again, there were some individual providers that people had issues with, but by and large, people were happy with their treatment. So some of these have already partially been touched on in terms of the discussion of social supports, but we did identify several well-known barriers to care, and we're hoping to contextualize those within the Nebraska setting. Financial issues are pretty common, especially among our lower socioeconomic areas. There are some supports that are available, but again, they're not offered across the board. They're not offered consistently, and people sometimes have trouble identifying what supports are available. Financial supports also include insurance. So one of our participants indicated that when she had the cancer diagnosis, she had to reduce her hours at work and her insurance was cut. Transportation, Nebraska is a very rural state, and transportation was definitely mentioned by some of our participants. Traveling an hour to up to 4 hours or more to receive care, even with localized, somewhat localized cancer centers, people are still traveling pretty far. And it's important when we're thinking about transportation that we're also thinking about scheduling. We had a participant who indicated that they were a caregiver, and one of the mother needed to go in for a colonoscopy, but colonoscopies are only offered first thing in the morning. And so their options for bowel prep were to get up at 3 in the morning to get to the appointment, or to rent a hotel and do the bowel prep at the hotel the night before. So scheduling definitely plays into what we're thinking about in terms of transportation and in terms of access to care issues. There was some indication that people were aware of limited awareness of cancer support groups, but several people across different focus groups indicated that those might be limited in terms of availability. So people that are in the Omaha and Lincoln areas tended to have better access to support groups compared to the rural areas, or that the support groups that were offered weren't specific enough to their needs. So there were support groups for the actual cancer survivors, but maybe not for the caregivers who felt like they could use a support group themselves, or it was specific to breast cancer and not available to other cancer types, or that most of the participants in the support groups were really old, and so younger aged cancer survivors didn't feel like they really fit into those support groups. So being aware of the support groups that are available and trying to tailor them to resources as well as needs. Language was primarily a barrier for the Hispanic populations, but there was also some indication that that our medical providers don't always use the easiest to understand terms, and that was an issue not just for those who were non-native English speaking. So some of the Native American groups indicated that their elders had a really difficult time understanding what all of the medical terminology was. Some of the Hispanic participants, even though they considered themselves bilingual, also really struggled with the medical terminology. And language support services for the Hispanic participants were not consistently offered. We had examples of people who were using their young children as their translators within the medical situation when they were getting their cancer diagnosis. We had examples of other people who translate for friends in the community but are not official translators. And that our Hispanic population is not homogeneous. We have people from all different dialects and regional languages. And so our language support services need to be able to accommodate a wide variety of not just Spanish speaking, but dialects. We did have examples of people who indicated discrimination in terms of how they were being treated across the process of getting their diagnosis and treatment. So we had examples of discrimination based on race, legal status, sexual and gender identity, and I would suggest even some discrimination based on how providers were responding to female complaints or symptoms versus some of the male complaints of symptoms. As I previously mentioned, lack of regular medical care was pretty persistent across all of the focus groups except for the non-Hispanic white rural group. So the African-American, the Hispanic, the Native American focus groups, and even the LGBTQ indicated that within their social groups, getting preventative or annual physicals is not an expectation, it's not standard practice. And so they're missing out on those opportunities to interact with the medical or healthcare profession, to get health education, to get recommendations for screenings, to deal with some of the underlying factors that are actually cancer risk factors. And so if we're not providing regular primary care, we're really not doing service to these communities. And those led to delayed diagnoses, delayed treatment, and more severe outcomes. Oops, wrong screen. So we did also analyze specifically for colorectal cancer screening themes. For those of you who are not super up on colorectal cancer screening, there are a huge number of different screening methods that are available. They have different frequencies of how often you need to do them. And so it's actually more confusing than just saying, go get a mammogram every year or two. The colorectal cancer screening, although there are more options, it leads to a lot of confusion. There was a general lack of knowledge and awareness about screening, about the screening recommendations, about the ages at which they should be screened, about who is considered high versus average risk. Specific comparison to breast cancer mammography was made that it's just not as widely talked about as breast cancer. People aren't as familiar about colorectal cancer. Participants across focus groups indicated that it's really important for their primary care physicians to really push screening. It's not enough to just say, oh, you're due for your annual screening. They use terms like insist or like very strong language when they were talking about how they needed their providers to talk to them so that they understood how important it was for them to get the screening. Participants needed more education about the different options, and some providers only recommend colonoscopy, and so people are missing the opportunity to have that choice in terms of what screening they're receiving. Pretty consistently with other literature, participants indicated fear, embarrassment, and cultural norms associated with colorectal cancer screening. Most of those comments were related to colonoscopies, but there were some who were embarrassed about having to touch their poop or collect their stool samples. There was a lot of joking and just discomfort with discussing anything that had to do with anything in the private areas, and a lot of sexual innuendo and connotation related to colorectal cancer screening. As I indicated, access was also a pretty consistent theme in terms of being able to schedule colonoscopies, having access to colonoscopies, or even accessing the stool-based testing. Our participants were asked to provide some concrete ideas about what we could do to improve screening in Nebraska. And so these are broken down primarily into informational campaigns. So how should we be delivering these messages? What should we be saying? As well as some other recommendations. So in terms of how they wanted to receive information about colorectal cancer screening, again, in line with the healthcare providers being their most trusted source of information, they wanted to hear about it from their doctors. They wanted to get those recommendations from their doctors, but they also wanted signage in the clinics. They wanted posters, they wanted pamphlets that they could take home and read about. Several different communities suggested that they have humorous billboards to get more general awareness of colorectal cancer and cancer screening. and that the billboard should try to downplay some of the sexual innuendo, try to make it more like a topic that people could actually talk about rather than being embarrassed about. Several of our different focus groups really were heavily into Facebook as a social media communication tool, and so they suggested social media as well as group text push-outs. Some of the other communities were more focused on one-on-one interactions and the need to have that face-to-face contact through health fairs or having informational messaging at senior meals. Partnering with community organizations was really highlighted, so that could be community service groups, religious groups, schools, employers, and so forth. And a smaller number of participants indicated that they prefer to receive information as public service announcements on TV or radio. In terms of messaging, a few different themes emerged, including trying to make it more talkable, so it's not a joking matter, that we need to discuss this, don't just be embarrassed about it. A lot of the messaging was focused on what you do now can have impacts in terms of how you're able to be there for your family later. So get screening now so that you can be there for your family. Several of the communities had kind of a fatalistic attitude toward cancer, and so overcoming that cancer fatalism. If people are being diagnosed at late stage and everyone that they know who's diagnosed dies quickly thereafter, there's a perception within the community that cancer kills, that it's not treatable, that there's nothing that they can do about it. So why know about it? Why worry about it? And so overcoming that disease fatalism was an important message. Both in terms of being able to get treatment earlier when it's more treatable, but also just to have that peace of mind to know that if you test negative, that you're okay for now. Other suggestions to improve screening included, the Ponca tribe uses grocery gift cards as an incentive for fecal testing within their population. And so not just the Native American groups, but some of the other groups were aware of that. And they also promoted the idea that it's important to try to incentivize preventative care, not just cancer screenings, but going in for annual exams. In line with some of the comments in terms of people's interactions with their healthcare providers, there needs to be some sort of provider education so that the primary care physicians are consistently recommending screening to all eligible patients, and that they need to be communicating that there are a variety of different testing options available. And they need to present that information in an easy to understand format, preferably with some diagrams or visual aids. And again, highlighting the importance of shared decision-making. So it shouldn't be my physician telling me to go get a colonoscopy or to go get a fecal test. I should be able to decide what type of test I want based on what my priorities are. So the focus groups also identified some underlying general community needs, the need to build trust between the medical community and the communities that they serve. There was some discussion about historical events that have caused great mistrust within some populations in working with Western medical care, and the need to be present in the community so that they can try to work to build those connections. Again, prioritizing regular medical care, making time for care amidst competing demands. So we have a lot of people who are hourly wage workers at low incomes that feel like if they take an hour or more off to go get medical treatment for themselves, they're not going to have the financial resources to support their family or feed their family. And so addressing some of those general community socioeconomic needs. Again, overcoming the sense of disease fatalism and building a sense of community around cancer, that you're not alone in this, that it's okay to talk about cancer, that people are there to help you, and just basic health education about a range of conditions. So that kind of goes in line with the primary care and needing regular treatment access. So there was a recommendation to increase awareness at the grassroots level that encompasses both organizations as well as trying to build that sense of community with the medical campaign, social media campaigns, again, provider education, providing more consistent support groups and more consistent offers of psychological services and counseling. to normalize routine checkups starting at a young age, and to have more opportunities for free or low-cost primary care and or financial assistance. Provider education incorporates both the staff as well as the physicians. They need education about interpersonal and listening skills, about diversity, equity, and inclusion, cultural sensitivity training, making sure to make referrals or to make people aware of language support services, and again, shared decision-making. So we do have several reports available on the COE website. We have started to get some of this pushed out into peer-reviewed publications. We're in the process of working on several additional manuscripts, as well as making presentations at professional organizations. So that's kind of the wrap up for the focus group portion of the needs assessment. And I want to just end really quickly on what our additional steps are for the needs assessment. So we are trying to collect additional data with some of the other Native American tribes in Nebraska. We are working to synthesize across groups, which is really time consuming, and to issue a final report on the focus group results. Again, we're working on various manuscripts with the intent that all of these sources of information are disseminated to professionals as well as to the communities themselves, and that they can help inform priority setting for the COE. My own research, again, is heavily focused on social determinants of health, including geographic medical accessibility, rural-urban disparities, access to care issues, and provider capacity, what services are available to whom, as well as a large focus on colorectal cancer screening with an interest in serving the Latino population. So with that, we have about 10 minutes left for questions.